Education Foundation. Today we have the pleasure of once again having Professor Hitesh Shah, who is the Professor of Pediatric Orthopaedics at KGMC Manipal. As you know, this is one of the high volume pediatric orthopedic centers in India. And today we are going to discuss short cases. It's going to be an interactive session. And so without much further ado, I would request Hitesh to start his talk. Over to you, Hitesh.
Thank you, Dr. John. It's a pleasure to be there, part of this program. Okay, my slide is visible?
Yes, sir.
Yeah. So, good evening all. Actually, we are going to discuss the few short case which is very commonly kept in the exam. So, case for the short case, then we will have few spotters because that may not come in exam, but it may be part of the OSCE. So we will start with the first interactive session, because actually what we will show the case or the deformity or anything, then I think some of the postgraduate can interact. This 3.5-year-old girl present with the foot deformity of the both sides, and the deformity was present since birth. So this is very. I will ask the postgraduate. You can.
Yes, sir. So we have that one Pushpinder, Rajan, and Subhansu, and many more. So Pushpinder, please answer this one.
Sir, this is a plano vulgus deformity, sir.
Yes.
Plano vulgus.
Plano valgus. You want to say the plano valgus deformity of the foot? Okay. What is the reason? Is it the common in the congenital plano valgus?
No, sir.
So what is the, what will you say if you see the right side image?
Yes, sir.
Is it a plano valgus or is it something else? You can see like
recurrent.
Pardon? So what do you look at the sole, look at the toes, look at the depression on the lateral side of the foot. Describe these, you'll automatically come to a diagnosis, okay?
It looks like a rocker bottom foot, sir.
Yeah.
Okay, good.
Good. So what you see that what Dr. John has said, that you need to see about the hind foot and you need to see about the forefoot, and what you see the depression on the lateral aspects.
So congenital vertical talus.
Okay, so it is another aspect is that is a congenital vertical talus. Okay, so it is that you can say that is the synonyms. It's a congenital vertical talus or the rocker bottom foot. Okay.
So is there anything in that will make you wonder whether it is a true congenital vertical talus or something else?
Yes.
Anyone else? If
To the heel in a CVT, in a bad CVT.
I think Avinash is also there. Avinash, you can answer that one.
Sir,
Yeah.
I think by appearance, it can be congenital oblique talus.
Okay.
Okay, why do you say it could be oblique talus?
Because
Vertical talus.
dorsiflexion is not that much, and
So in vertical talus, there's more dorsiflexion.
yes, sir. I would like. I think there is more dorsiflexion.
So what is the difference point in a clinically and other point also between congenital oblique talus and congenital vertical?
Sir, in clinical, there is some protrusion in the medial aspect of the foot.
Okay. In which condition?
In
Oblique.
Oblique, in oblique.
In oblique. And vertical talus?
Sir, in vertical talus, I don't know, sir. I don't.
So you don't think there'll be a protrusion on the medial side in a vertical talus?
Sir, there will be a protrusion on medial side in both cases.
So then what is the difference?
What are the things which make you think something different? And we are just talking clinically now, okay?
Yeah.
Sir, amount of deformity will be more in vertical talus.
Okay.
And
So what are the parts of the deformity? You talked about dorsiflexion. Now, where is the dorsiflexion more in vertical talus?
Sir, in forefoot, sir.
yeah,
In forefoot,
fourth-
okay.
Yes, sir.
And hindfoot?
Sir, hindfoot will be in equinovalgus, sir.
Yeah, so there's normally in the very severe CVT, there will be actually equinus of the hindfoot, okay.
Yes, sir.
So
that's
that's why
why
it is divided into two parts, sir, rigid and
Okay.
Yes, sir. That's why we call it rocker bottom.
Okay. So what are the deformities in the vertical talus or oblique talus? There is a forefoot deformity and hindfoot deformity. The forefoot deformity would be forefoot abduction, forefoot eversion, and forefoot dorsiflexion. And where is the pathology in oblique talus or a vertical talus? What is actually the
So the position of talus, sir, actually talus is not, I mean, the subtalar joint and the tibiotalar joint is not congruent, and talus is vertical, and it is actually anterior to the calcaneum. I mean, sir,
talus is dislocated on navicular.
okay
Is
talus?
the talus dislocated on the navicular? Is the navicular dislocated on the
It's
talus?
navicular dislocated on talus.
Yeah.
So
Okay.
always talk about the distal joint.
Yes.
So it's like partially right, but it's that you need to say about describe the distal most part compared to the proximal part. Whether you are describing a fracture or a deformity or whatever say. So very peculiar and very specific, there would be dorsolateral dislocation of navicular over talus, not about tibial, not about subtalar. That may be the subtalar and tibiotalar deformity may varies, depends on the severity of deformity, but pathology lies on the talonavicular joint. The talonavicular joint would be dorsal and lateral, dorsolateral dislocation. So very peculiar part of the vertical talus, whenever the navicular is displaced dorsally and laterally, the head of talus would be prominent. The difference between the oblique talus and the vertical talus, the vertical talus would be dislocated. The talonavicular joint is completely disrupted, while in case of the oblique talus, that would be subluxated. So the subluxation may be reducing specific,
Plantiflexion.
which is specific position. So what is that specific position? It will get reduced.
Forced plantiflexion.
Yes, it is in forced plantar flexion. So the forced plantar flexion and inversion, if talus head would not be prominent on the plantar and medial aspect, that would be a characteristic of oblique talus. While whenever you see the prominence and the dorsiflex forefoot and the hindfoot would be in equinus and valgus, this is a characteristic of the congenital vertical talus. Which is congenital vertical talus would be different than the oblique talus, where hindfoot deformity is not present or less severe in case of oblique talus, while in case of the vertical talus, hindfoot deformity would be more severe. Similarly, forefoot deformity, talar prominence, and severity of deformity, forefoot abduction, eversion, and dorsiflexion would be there in oblique talus. What do you do? Isn't that the X-ray in that? So what do you do with that? If you see the child with case with either vertical talus or oblique talus.
I think Sachin has not answered it. Sachin,
Yes, sir.
What is the management for this one?
Uh, sir,
Modality of the investigation in orthopedic or pediatric orthopedic.
Anyone else? Neeraj has
Serial manipulation and casting, sir.
okay.
Okay. Yes.
Reverse Ponseti.
Yes, sir.
But do you want to confirm whether it's oblique talus or vertical talus?
Sir, if it is reducible on force plantar flexion, then it is oblique talus.
Okay.
If it is not reducible, sir, it is congenital vertical talus. Clinically, sir, we can differentiate from this thing, sir.
So you would like to take what is the difference between the vertical talus and the clubfoot? Both will have the treatment of choice is manipulation and casting. In the clubfoot, we all learn that it's become gold standard is Ponseti.
Ponseti technique, sir.
In case of the vertical talus, is the reverse
Ponseti.
Yeah, but very important message: the CVT in the clubfoot don't require any X-ray, but in case of the CVT for documentation, the X-ray is needed. X-rays are necessary investigation for a diagnosis because it will give you idea that what is the severity of deformity, and it will differentiate between the
rigid and
oblique talus and vertical talus. Okay. So what are the X-rays you can order?
Sir, epilateral and oblique, sir.
Epilateral oblique. Anybody else?
The force plantar flexion lateral view.
Okay, the force plantar flexion lateral views. Okay. So we'll show you the X-ray. These are the X-ray. You can see the left side X-ray and the right side X-ray, the both side. Would you say what kind of things what pathology is here? We are dealing with either oblique talus or vertical talus.
Sir, vertical talus.
Okay, why do you think so? What is the reason that can in X-ray
vertically located, sir?
Sir, one person is plantar flexion, plantar is a dorsal.
So what actually we'll see in plantar flexion X-ray? What actually we can find out, because we ask for investigation, correct? So what actually is needed to draw, needed to check or diagnosis of vertical talus? Talus is vertical in sometimes in oblique talus also, when there is a severe obliquity would be there.
Sir, talocalcaneal angle, sir.
Okay, talocalcaneum angle. Okay, it would be more or less. Talocalcaneum
more than 40, sir.
More than 40. But talocalcaneum angle will give idea about hindfoot valgus.
Yes.
Doesn't say. Again, what we said is what is a pathology? We discussed already. What is a pathology in vertical talus?
Talonavicular dislocation.
Navicular dislocation on talus.
So what is the more important angle on the lateral view?
Sir, longitudinal axis, sir, talus and first ray.
Yes, that's correct.
Okay, so what's that angle called?
Mary's angle.
Okay, good.
Mary's angle. Yes.
So it is very important to draw the axis of the talus and the axis of the first ray. Okay. Can anybody say what we teach is talonavicular joint, talonavicular dislocation, talonavicular subluxation, but in X-ray we measure talus and first metatarsal. Why? Because that may be the question in this national board also.
Because deformity is on hind foot and foot. So
why not measure the angle of the navicular to the talus?
Talus, no? Simple question. Is it complicated for all? It's simple. Why we have see one thing you must understand today. One message: there is a dorsolateral dislocation in vertical talus, the dorsolateral dislocation of talonavicular joint. And when we take about X-ray, that is a forced plantar flexion X-ray, but we measure talus and first metatarsal axis. Why? It is very simple.
Sir, arch. This is a plain flat foot deformity, sir. So
Okay, I will
Sir,
come.
notification is for
Yes.
navicular.
What is that?
Sir, before 3 years, there will be no ossification center for navicular.
Okay.
Exactly. So you won't see the navicular. Okay.
You won't see the navicular. Exactly. Please understand that whenever we take about X-ray, the only 3 bone would be ossified very clearly in the at birth. Talus and calcaneum is always there. All 5 metatarsal are always there. And whenever there is no deformity, talus would be in line with the first metatarsal. So if we are talking about the relationship between talus and first metatarsal, it is maintained. That means it is in line. If it is not maintained, that means the navicular is not in line. So one important point, if you say the stress plantar flexion X-ray, when you see the line of the first metatarsal and the talus would be exactly parallel, that will be about the oblique talus, because it will not be considered about the vertical talus. Where it is not getting reduced, it is called as the vertical talus. So always check about 2 axes, longitudinal axis of the talus and the first metatarsal. Yes, you are correct. The AP you can say about the talocalcaneum angle, but that will give you only severity. And the first metatarsal also angle, that will give you idea about the forefoot abduction. That is relationship of incorrect compared to the hind foot. Similarly, somebody mentioned about talocalcaneum angle, that is more than normal. That will give about the hind foot valgus. But the most important is the talus and first metatarsal axis in plantar flexion lateral view. Remember, this is very common DNB question and DNB OSCE also. The talo first metatarsal X-ray. Same patient. Can anybody read this? Somebody has taken the X-ray. I'm surprised.
I think, yeah. Avinash?
Yes, sir.
Read this one.
Same patient. Same patient. Is it difficult? I'll mention that.
a fusion, sir.
What?
Read the
Left side.
X-ray.
Sir,
Read the X-ray. Na? First, just look at the X-ray. Describe what you see. Don't go jump to a diagnosis. Okay. Do you see a difference between? Are you happy with the X-ray? Is there a problem with the X-ray?
sir, X-ray is, I mean, it's not a true anterior view.
So what do you describe? What are you seeing on one hemipelvis? What are you seeing on the other hemipelvis? Is the pelvis squared? Is it tilted? Describe all those things before you jump to what the
So
diagnosis is.
this is an X-ray of pelvis with both hip of immature bone.
Okay, good.
And it the view is not true anterior-posterior, but slightly.
So to talk about the pelvis, is it squared or is it tilted?
No, sir. Sir, pelvis is tilted. It's not square.
Okay, fine. Then you talk about what you're seeing in terms of are the obturator foramens looking at you the same way?
No, sir. Obturator foramen of one side is visible and other side is not visible in this X-ray, and the left side, one side is more adducted. Hip is more adducted in one side and then the other side.
But your pelvis is tilted. So how do you say the hip is adducted?
Yeah.
What
Will you
about
see
the
all the bonds? Will you see how many bonds you will see here when you see your pelvis in both the X-rays? What are the bonds will visible?
Sir, ilium is
Whether
visible.
iliac wing is visible, both sides.
Yes, sir.
Okay.
Yes, sir. Both side iliac bone visible.
And what does the iliac bone articulate with?
With articulate with what? Articulate with
sacrum, sir. One ela of sacrum is upset.
Sacral ela is upset.
Finally, you guys are getting to it. Okay.
Yes, so it is the message is very clear. Whenever you see the vertical talus, there is a different why. It is not for sacral agenesis. This is an X-ray of sacral agenesis, but it is not kept for the sacral agenesis. Message is very clear. The clubfoot, by and large, very commonly seen it's idiopathic, where in vertical talus, it is 50 to 60% is non-idiopathic. So you will always check about whether it is multiple congenital contraction, whether it's a spina bifida, whether it's neuromuscular, whether it's a trisomy or a syndromic. This is very, very common with the Edwards syndrome, very, very common with the non-idiopathic in nature. So always, whenever you see vertical talus, always examine the spine, always examine the upper limb, always examine the associated hip and knee abnormality, because that may be always associated with the vertical talus, contrary to the clubfoot. Okay, that is message, but again, this X-ray may come with you. I'm not going in the treated. Anybody can say why need to treat this? Why need to treat vertical talus? Not about sacral agenesis. Okay, so everything from say vertical talus. We finish the first vertical talus and we go forward.
Good answer. I think Neeraj is not there. Yes, Sachin.
So the question is, you have a deformity.
Yes.
What is the reason you want to treat it? Is there going to be a problem later, or is it just going to be a deformity?
We will try. I think Pushpinder will be able to answer this.
Okay, anybody volunteer or we will go ahead.
Yes, Amil. Amil is trying, yes.
Sir, but not understanding question. Sir.
So you have a deformity of the foot, okay? You want to treat it for, one may be the cosmetic reason, the other, there could be a functional problem later. Is there going to be a problem later if you don't treat these deformities? Is that clear, or is that also difficult to understand?
No, sir. There will be a problem later.
So what problem will you have?
Sir, rocker bottom.
It's already there.
Rocker bottom foot is there from the beginning. So what is the problem?
Sir, I think limb length.
Why should limb length be a problem if there is a bilateral rocker bottom foot?
Sir, unequal pressure.
Sir,
okay, unequal pressure on what?
Sir,
ankle subluxus.
So normally when you walk, where are the pressure points? Simple.
What are the pressure points? Yes, when you walk on the foot, normal foot.
The pressure point on calcaneum and first metatarsal and fifth metatarsal base.
Base of.
Yes. And here, where's the pressure going to be?
In vertical talus.
May I, sir, go talus in avian, sir?
Yeah.
Come on.
The pressure will be on mid foot.
A lot of background sound. Where's that from?
Yes, sir. Everyone is okay.
Pressure will be on mid foot, sir.
What's pointing down? What is hitting the ground when these children walk?
Head of talus.
Talus is hitting the ground.
Finally.
Is that a normal situation?
No.
No, sir.
So
okay. So we'll see that is what is very common is that appearance. The appearance will be there. It's the cosmetic. It's not the healthy looking or good looking thing. Then what we said is the abnormal weight bearing. The weight bearing will get affected. That whenever the weight bearing is there, it will be there on the ball of the great toe, the fifth metatarsal, and the calcaneum. The tripod would be lost, and the surface contact surface area is very, very less. That will be on the medial side. And if you see this, what happens that in the long standing, if it is a pressure built up, it's not treated, the 8-year old child present with that, it's excessive capacity. And if it is associated with the spina bifida, this can break down. And this is untreated child patient with the adult is there. And is because of the mechanics is being altered, it will develop the very, very, very early arthritis and contrary to the clubfoot. Remember, the clubfoot patient that we all of us will see the many untreated clubfoot in third decade, fourth decade, fifth decade also. So these are the specific reason we need to treat that, and this need to treat also early and good. This is the broad guideline. That's not always mandatory. If it is a supple, you can treat with manipulation up to the older child, but it's a broad guideline. There is a young child, you can do about the manipulation and casting, followed by the minimal invasive surgery to reduce about the talonavicular joint. Older patient, it can be treated with the soft tissue release, either of the approach, either the single approach, dorsal approach, Cincinnati approach, posterolateral approach, or a Kumar Ramsey tree approach. And even in older patient where there is a navicular is arthritis, it can be done with the naviculectomy or subtalar arthrodesis. An older patient, when it is with arthritis, it's required critical arthrodesis. Okay, so we'll conclude the first piece today. Any question on vertical talus? Dr. John, you want to ask anything?
No, that's, I think, pretty comprehensive. I think it's important to understand the reasons why you're treating it, also how the problem is different. The treatment, I think, may be a little beyond what the normal expectations will be in terms of details. But what you need to know is the idea of the reverse Ponseti. And most of them will, like in the Ponseti, all you do is a tenotomy at the end. Here you may have to add wires to maintain your correction when you're doing your tenotomy. Okay, so here also you may need to do it. So remember, even though this is an opposite deformity, the TA is often tight. There are other tendons on the lateral side which are tight. Okay, but you can usually stretch them out. But you may still have to do a tenotomy to get the equinus of the hind foot corrected, and you may have to put wires to maintain your correction. Whether you do it percutaneously or you do an open reduction, that will depend on the severity of the deformity. Okay.
Any question from any postgraduates? Anything?
Yeah. So I think everyone knows what is reverse Ponseti. If anyone can explain that one, because that is the, I think, easiest question they can ask in there.
So what do you do in a Ponseti?
Yes. Pushpinder, you only can answer. Pushpinder or Avinash? Anyone who is?
Sir, in Ponseti, we correct the deformity in sequence. First we correct cavus, then we correct adductus, then we correct varus, and then at last we correct equinus. So we use head of talus as fulcrum, and we manipulate the foot to correct in sequence. So,
okay. What will you do in the reverse Ponseti? Reverse Ponseti. Anybody can say about that if we have idea about the reverse Ponseti? So the head of talus we use as a fulcrum also in a reverse Ponseti, but here the deformity is opposite because there in clubfoot there is a forefoot adduction, where here is a forefoot is abducted. Where it will cavus, here it's a dorsiflexion. So that is different. So you have to do the inversion and adduction. It's reverse than that. In Ponseti, you have to do the abduction and external rotation. Here is that reverse. In Ponseti, abduction and external rotation. Here, inversion and adduction. That you have to do. That's reverse. Just opposite to the Ponseti. But the head of talus would be the fulcrum. And that is the reason you need to use that force in a reverse direction. That is a reverse Ponseti. Okay, and reduce the talonavicular joint. But the contrary to the Ponseti, as Dr. John mentioned, we never put any wire in case of the Ponseti. We always do only the hindfoot minus correction by stereotomy. In case of the first Ponseti, along with the hindfoot equinus, we need to reduce the talonavicular joint and maintain it. The only issue with the talus is that talus doesn't have any attachment of the tendon, muscle or tendon. So it is very difficult to maintain that position. That's why you need to put the wire across the talonavicular joint. Okay.
So, sir, for forefoot, it is, I think, abduction. It is abducted, so it is adduction and
inversion.
And plantar flexion also, sir, or because that is also dorsiflex. Okay.
Yeah. All three divers, it's abducted, inverted, and dorsiflex. So it is the adductor, inverted, and plantar flex.
Okay. Yes.
And the only other thing is that, unlike which is not reverse of the Ponseti, is that you want to try and avoid causing more equinus, okay? Because the back heel is also tends to be in equinus, which is the opposite of the. Which is the same as in a clubfoot, except that is equinovalgus instead of equinovarus.
Yeah.
Okay, so again, your thumb still remains on the head of the talus, but the forefoot is being pushed the other way. Okay.
Yeah. But the thumb would be the head of talus, but head of talus is medially in CVT, where it will be there laterally in clubfoot.
Exactly. Yeah.
Both are different.
So head of the talus is going to be on the medial side, inferomedial, and you try to get the head pushed laterally, but basically that's the fulcrum. You're trying to get the forefoot into equinus, varus, inversion and adduction, okay, and also plantar flexion.
Okay. So we'll go on the next because 9:20 will finish. Can anybody say what is the diagnosis? What is visible here? Is it like vertical talus? Because the similar looking foot, that's why it choose the similar problems with the both, because they can differentiate. Is it like a rocker bottom foot?
No, sir.
So what is it? Any idea? Anything?
So just look at it, and where do you think is the deformity? Does the foot look normal or abnormal?
Sir, foot look normal. Distal
so where is the deformity?
Deformity is a distal tibia.
Okay, so what do you think is the deformity?
Sir, distal tibial agenesis.
Agenesis. So always think of more common things than more uncommon things, okay?
Congenital pseudoarthrosis. Pseudoarthrosis.
Pseudoarthrosis is which way?
What are the deformity of leg or leg
which
component?
Way does the pseudoarthrosis deformity go?
Sir, go varus. This is valgus.
What do you call it? Anterolateral bowing of the tibia. Okay?
Yes, sir. Anterolateral.
So is this an anterolateral bowing?
Here is where is apex? Where is apex? Anterior or posterior?
Apex is anterior or posterior?
Sir, apex is posterior.
Okay. In medial or lateral? Medial or lateral?
Medial, sir. Posteromedial.
So,
okay,
so diagnosis simple. You only saying just combine all together. It is from birth. What is?
Congenital
Congenital? Yes.
posteromedial bowing of tibia.
Yes, it is congenital posteromedial bowing of tibia. Okay, so these are the X-rays. Okay, this is. Yeah, can anybody can summarize what will you do for this? There are only two important aspects. Where is the apex of the leg? Is it anterior or posterior, medial or lateral? If the apex of the leg deformity is posterior and medial, that is called as the posteromedial bowing. Okay, remember, most of the tibial deformity is referred as the pseudoarthrosis tibia, but it's not a pseudoarthrosis tibia. This is a congenital posteromedial bowing, and it may be associated with the calcaneovalgus, which actually happen in this child. Almost the shin and the dorsum of foot is touching together. Okay, so can anybody volunteer? What will you do?
I think if someone else can answer, Neeraj.
So we've seen a few of these, and I don't know if you guys have seen it, but certainly.
Sir, we have to do deformity correction by osteotomy.
Wow.
Somebody told, actually, I will give
What
you
is the natural history of posteromedial bowing? Okay.
Sir, it gets corrected. It might get
But then why are you
corrected.
doing an osteotomy? If you're saying it gets corrected on its own, why do you want to do an osteotomy?
So serial casting and soft tissue contracture release. That.
He just said it gets corrected on its own. So why do you want to do serial casting?
Okay.
So a very important message, most of the deformity gets resolved over a period of time, but only the issue
shortening.
Shortening. The limb length discrepancy would be the big issue here. So if you see that the diagnosis is a posteromedial bowing, the same child after the 5 years, you can see the difference. Deformity gets corrected, but that is a remarkable limb length discrepancy. There is difference between the left side and right side. So for those who can understand pictorial, we can see the deformity at 6 months, same child after 1 year, the same child after the 2 years, 3 years, 5 years, and 6 years. Because that what is the difference between the 6 months? It's got mostly got corrected. It's not completely resolved always, but
yeah,
if you see the serial X-rays, it gets corrected, right? Important message here is there the deformity is in reverse than anterolateral, where anterolateral is always progressive, and you can't leave it like that. So always remember anterolateral and reverse is posteromedial. The clawfoot opposite is vertical talus. Here the posteromedial bowing, it is benign in character. Benign means there is no issue, but the fracture of the tibia would not be issue. Benign means it will never have the fracture. While anterolateral bowing, there may be the possibility of fracture. There may be associated problem like residual deformity after the growth potential would be less. Or second, very commonest is that limb length discrepancy. There are other associated issues too, but we will discuss only two. That is the residual deformity and limb length discrepancy. So that if you see that another child is got very well corrected, the same child at the skeletal maturity, you can see that its deformity was quite okay and it's got corrected very well. So, can anybody can say quickly if there is a shortening, what will you do? Because when we say there is a residual deformity or shortening.
Sir, shoe raise.
Okay. Yes. Any other issue? Any other treatment modality?
So how much do you think is the normal, how much shortening do they end up with roughly? I mean, I can't say an exact number for every patient, but.
Less than 2 centimeters.
Who told you this? So if it's less than 2 centimeters, do you need to do anything?
No, sir. Only Surgeries.
Up to 3 centimeters, we can
Only.
give other.
No. The question I asked was, in these patients, what is the eventual shortening approximately that they end up with?
Sir, up to 5 centimeters.
So you just said you don't have to do anything. It's only 2 centimeters. You keep changing. Why do you change in between? Yeah, so the normal shortening would be 4 to 5 centimeters. Yeah.
Yes.
Okay.
So I
It could
think-
be a little more or a little less, but that's approximately roughly where most of them end up with.
Yeah.
And they often have some residual. So if you look at the final X-ray that Hitesh showed, there will be some residual angulation, which is very minimal often. Sometimes it's almost fully corrected, but be prepared to have some residual angulation. So you need to counsel parents on all this, okay?
So, sir,
Now,
can
the
we
5
expect-
centimeter shortening, what would you do?
Yeah. Very simple question. 5 centimeter shortening, what will you do? Or expected 5 centimeter at the skeletal maturity.
Sir,
Expected.
Surgeries from outside. So,
For 5 centimeters.
5 centimeters is like too much, maybe. 2 each is quite a lot for Surgeries. What will happen? One simple question. What will happen if we have the raise more actually? If person has got 10 centimeter limb length discrepancy, will give 4-inch raise?
no, sir.
Okay. So why will demarcate the more? More sole raise?
Will maybe difficulty in walking or maybe tapal.
Yeah. So you'll have the repeated ankle sprain and ankle will cause problem. So you can't give the more than that. So the 5 centimeter, let us not complicate. 5 centimeter, how can we address?
If there's
It
a
is
5 centimeter shortening in a patient, how can you address it?
of lengthening, sir.
Okay. Any other options?
That's option. Okay. We agree. Agree.
Epiphysiodesis, sir.
Epiphysiodesis. Okay. Yes.
Epiphysiodesis of which side?
Which side and what?
Of the normal.
Normal side.
Contralateral side, yes.
So at
Which
what
is-
stage will you do that?
Less than 2 years of.
At 2 years of age?
No, sir,
Sir.
less than 2 years of mature.
Growth potential.
Yes,
development.
growth 12 years. Up to
So-
12 years we can.
So which physis you will do? There are 4 physis in one limb. And which side, medial or lateral?
Sir,
Medial, sir.
Bilateral.
Right.
in sir normal in the normal
Normal.
proximity.
Let's say.
So is there a third option? Okay, you mentioned, we'll come to details on that. Is there a third option?
Sir, osteotomy, sir, opening.
May not
Osteo-
correct 5 centimeter. Yeah. It's only open wedge osteotomy cannot correct 5 centimeter.
Yes, sir.
So any limb length discrepancy, what are the 2 things you can do? One is lengthen that side, the other is shorten the opposite side.
Shorten the opposite
Very
side.
simple. Okay, now depending on the amount, so if it is up to 4 to 5 centimeters, you can actually shorten the opposite side. It's not something most people will accept in India, but if you have a particularly tall patient, that is something you can suggest. Okay. Okay, but most people do not accept shortening of the opposite side. So the chance, what you need to do is lengthening. Okay.
It's
And the growth modulation, you can do, but here you have to do a growth modulation on both sides. You can't do one side. Okay. It's not as if you're correcting a deformity. You can, you're trying to reduce the amount of length that limb has. So you need to then look at your growth charts and then decide at what age you can do it to expect it to equalize by skeletal maturity.
So it's very rightly said you need to do about the charting growth chart The serial follow-up say how much limb length discrepancy, whether it is progressive, is it static. By and large, in case of posteromedial bowing, it would be static. Percentage remain the same, but opposite will grow in the same proportion. So you can anticipate what is amount of limb length discrepancy at the skeletal maturity. You can plot the graph and decide about that. How can we correct by doing epiphysiodesis? It is preferable to find out and do the age where we can do the opposite proximal tibial epiphysiodesis in order to keep the knee at the same level. If you do at femur or other part, the knee would be at different level. So because of the advancement in temporary epiphysiodesis, now the people can do it quite early and take it out. But when you do the permanent epiphysiodesis, you can put the chart and do that. By and large, it is the option would be either the lengthening, either the shortening, or the epiphysiodesis. If limb length discrepancy is expected or to be at less than 2, yes, the stallage would be there. And if it is more than 6, then you need to have a combination. You can't do only the epiphysiodesis because overall stature of the patient will remain the less. Okay, so you need to have a combination of either the lengthening, the shortening, or lengthening with epiphysiodesis, contralateral epiphysiodesis would be preferable. Any question?
So in one way of looking at it is to keep it simple, is to just lengthen the affected side at skeletal maturity. But remember, lengthening is not always a very simple process in these. They often develop valgus at the knee, okay? So that's something you need to watch out for if you're just doing a lengthening in these patients. Sorry, not so much in this. That is much more in fibular hemimelia.
Yeah.
But here also you need to watch out for, always watch out for any deformity occurring when you're lengthening the limb, okay?
Yes.
And it's not without any complications. You can have either less regenerate or delayed healing and all sorts of things that you need to watch out for when you're doing lengthening. While shortening is a much simpler procedure in terms of complications.
And single shot also. The shortening is simple, single shot, while lengthening is actually long, tedious procedure. So always prepare the family. If you are doing about the lengthening, it will take few months. At least whatever amount of the lengthening you do at that much month will be involved.
The problem is getting people to accept it is not easy.
Yeah.
At least I found it very difficult to.
Yeah. But I think epiphysiodesis is a simple process.
Yeah, epiphysiodesis is much more acceptable.
Yeah.
Because they don't look at it as shortening. You tell them you're trying to equalize the lengths.
Yeah.
When you're deliberately shortening it, there's a mental block to that in a lot of people.
Yeah, the the advanced option is that opposite timely epiphysiodesis. That would be the best option. I think it would be the best option. If the limb length discrepancy is less than 4.5 or 4 centimeters. More than that, yes, it is. Even epiphysiodesis would not be a good option.
It does not give you enough,
Yeah, it will not give you enough. Okay, Dr. John, you have to go that this time, so we'll stop. I will not further. I think it will be okay. Is it okay, Janki? Any question?
Yes,
1 minute. One question.
Sir, I have one question, sir.
Yes, yes, ma'am.
Sir, how much time it takes to get a desired outcome in this situation, in this condition, sir?
How much time it will take?
Yeah. Yes, sir.
For the deformity.
How much time?
After doing a epiphysiodesis, sir.
Okay, it depends. If you do that is actually the general. The rule of thumb is there. Distal femur grows 9 millimeter per year. Proximal tibia grows 6 millimeter per year. So that rule you can apply that. How much the growth left. So if it is female, 14 years it will be mature. By and large, if otherwise Indian children, female may take and menarche quite early. So it's not predictable. But generally, the 14 years for the girl and 16 years for the boy. So if we have the 3 centimeter limb length discrepancy, you can divide the 6 into the 3. So it will take around 5 years. So you have to do at 9 years in female. And in male, if it is there, you have to do around 11 years in that. So it will take around that much time. That is rough estimation, but depends on that. You can use about which chart, whether the Eastwood chart or whether you use the Colin Mosley's chart, depends on that. You can do about. But rough all are same. Whether you use Palas multiplier methods, all are the same. All are the same.
So just one thing, sir, because it is lower tibial deformity, is it the lower tibial physis which is affected, or both tibial physis is affected, sir?
No, the tibial physis would be not always normal. Distal tibial physis is affected, but you don't do the epiphysiodesis of distal tibia because that is fibula is also
You have
involved.
less growth in the distal tibia, okay?
Yes.
Sir,
Femur and proximal tibia is where most of the growth in the lower limb takes place.
Yeah.
So if you want to
can this condition be diagnosed in antenatally?
Yes.
probably, yeah.
Yes.
Because actually when these children are born, the foot is literally parallel to the tibia.
Yes.
Okay. So when they are born, it looks much worse than even a clubfoot deformity because the foot is literally lying on the tibia.
Yes, sir.
So you need to really counsel parents about the fact that this is going to correct because all of them are very anxious to get something done at that stage. And therefore, you see a lot of people putting casts and things like that, which are actually totally unnecessary in most situations. Okay, every now and then you'll get one where the deformity is not correcting. So it's not that you just tell them it'll correct. Tell them 99% it'll correct, but we need to watch it. And if it is not correcting, very rarely you may have to do an osteotomy to correct the deformity.
Yes.
But it's very rare. And 90, I think we've had to do it in one patient. And some of them not true posteromedial bowing. They have some other sort of syndromic thing added to it.
Yeah.
Okay.
Yeah.
Sir,
Thank you very much.
Sir,
Yeah.
sir, in this case, sir, at maturity, can we do, sir, femoral shortening?
That's what we said first. Femoral shortening, strictly speaking, you can, but then you have to explain to them that the knee joint levels will be slightly different. Okay, it doesn't actually make so much sort of functional difference, but they need to understand that their knee joint levels will be different. Okay.
Yes, sir. Yes.
If the knee is stiff, that's something which people do quite often. But if the knee is mobile, people try to avoid doing it in the wrong, in the opposite other bone. But there are situations where you need to do a lot of lengthening, and the shortening may just be in the femur, but you may lengthen both tibia and femur.
Yeah, that is the exceptional cases we do. We do the stiffness and other problem. It's not unstable joint, then we do that in a different segment. But preferably the same segment. Because it will be.
Yes, sir. Thank you.
Okay.
Thank
Right.
you, sir.
Thanks very much, Hitesh. As usual, very interesting and important topical cases. I think these are cases which could well be kept in your examinations if they are around at that time. And you certainly, if you know how to deal with them, it will give you a lot of credit marks because these are cases which are not seen very often. So I think it's will be good for you if you get them and you know how to answer them.
Yes.
Thank you very much, sir. It was great, sir.
Thank you, Dr. John.
Great. See you guys next time.
Thank you, sir.
Okay, bye.